Welcome back to New Method Live. I am so excited that you're here. And today we're going to do things a little bit differently. Usually I am solo here talking to you, but in addition to the podcast that I have, I'm sometimes a guest on other people's podcasts. Recently, I was a guest on Dr. Ovadia's podcast, and the conversation went so well that I really wanted to share it with you guys. So today, he's going to be a guest on my podcast. Here's his bio. I really hope you enjoy it. Let's do it. After growing up in New York, Dr. Ovadia graduated from Accelerated Med program at Penn State University and Jefferson Medical College, now Sidney Kimmel School of Medicine at Thomas Jefferson University. He then went on to complete a residency in general surgery at the University of Medicine Dentistry in New Jersey. I went to school there. Robert Wood Johnson Medical School, and a fellowship in cardiothoracic surgery at Tufts New England Medical School. Dr. Ovadia has practiced cardiothoracic surgery in Beaver, PA, and Clearwater, Florida. In 2020, he established Ovadia Cardiothoracic Surgery and now works as an independent contractor cardiothoracic surgeon in various locations throughout the U.S. In an effort to overcome his personal lifelong struggle with obesity, Dr. Ovadia adopted a low-carb focused way of eating in 2015. He has maintained a weight loss of nearly 100 pounds, and since March of 2019 has maintained a mostly carnivorous way of eating. He has extensively researched the health benefits of low carb with a focus on heart health through many hours of reading, medical literature, books, and listening to podcasts, as well as personal discussions with many physician leaders and citizens scientists involved in the low carb movement. He also wrote a book. You're going to love this title, guys. It's called Stay Off My Operating Table. Dr. Ovadia discusses the principles of optimizing metabolic health to prevent heart disease and other chronic issues. So I'm going to let Dr. Ovadia actually his bio keeps going, but it's long. And I just want to tell you this, he's super impressive. And here's the bottom line, because my audience knows I like to do everything in Cliff Notes. The bottom line is this guy's the real deal. He is a cardiothoracic surgeon. He goes and fixes people's hearts. And he realized, and he's going to share with us what it takes to not end up on his table. And I really want to bring this to you because I think one of the things we're missing a lot in the functional medicine world is having people from conventional medicine education kind of come over to this side of the vortex. So welcome to the New Method.
Thank you, E. It is so great to be here with you. I really loved the discussion that we had when you were a guest on my podcast, and really looking forward to continuing it. And, it's interesting, the intro that you gave, and talking about sort of crossing over between the, traditional medical space, I guess we could say, and the functional medicine space. And, I fully admit, for a long time, I was a standard physician in the standard medical system. And, I was doing my heart surgery, and I, was following standard advice. And that led me to a place that I was very unhealthy. And I was recognizing that it really wasn't serving my patients well. And through my personal journey first to overcome my own health challenges, and then that now has spilled to my professional life as well, where I realized that there's a better way for me to be helping people. And that's my mission now, to keep people off of my operating table, because the reality is that the surgery that I do, yes, it's a great help to people at the time that they need it, but they would be much better off if they never needed the surgery in the first place.
Amen. And you brought up a lot of really good points in this, in that I find that most of the people in functional medicine, because functional medicine, I don't know if you were actually certified, I went to school for it, but in functional medicine, we're all providers first, NPs, PAs, MDs. And on this side, it's either we've gone through a personal journey ourselves, or someone that we love has gone through a personal journey. And conventional medicine, which is wonderful, I'm not against conventional medicine at all. In fact, I believe what we're doing is conventional medicine done right. We find out that there's limitations or inaccuracies, and then we have to kind of dig a little deeper. So I just want to paint a picture that you were at the time a cardiothoracic surgeon, cutting people open, fixing their hearts, but you were obese, right?
Yeah.
And did that ever occur to you or anyone else how incongruous that is?
Well, it really should have. And to clarify, I wasn't just obese, I was morbidly obese. I was pre-diabetic and I was clearly pretty unhealthy. I'm sure some patients may have been thinking that, but no one really ever said anything to me, and quite frankly, none of my colleagues did either. And it's interesting as we go along and talk about my journey, one of the things we may touch on is, my colleagues are more concerned about my health now than they were back then, which is pretty ironic. But um, you know, I think on some level, I understood it to be, incongruent. But really, I didn't know what to do about it because, at that time, I was following all of the advice that I had learned to give. In school, I had done the eat less, move more, and eat a low fat diet and count your calories. And I had some short term successes, but really it wasn't successful over the long term. And I, like many others, I think many of our colleagues, chalked it up to, oh, it's my genetics, and
Mm.
this and that, and I would make the usual excuses. I'm too busy being a heart surgeon to go to the gym and pay attention to my own health. But now looking back, I can clearly see, how problematic that should have been for people. And, but unfortunately, our healthcare system is geared towards taking care of sick people, fixing their problems when they are sick. And, quite frankly, I am very good at doing that as a heart surgeon. I get good results. I took good care of my patients. I take good care of my patients. So, on some level, I guess that's all that really mattered to the healthcare system. But I now realize how much better we can and should be doing. And so that's where the integration, like you said, between the functional and the, osteopathic traditional medicine comes into play.
So what was the moment when you were like, this is not making sense? What tipped you over the edge to start going down the vortex?
Yeah, so really, it started for me. I was actually, ironically enough, at a medical conference at the Society of Thoracic Surgeons, and the guest speaker that year was Gary Taubes, the author and journalist. And Gary started talking about, at the time he had just written The Case Against Sugar, and he started talking about the types of food that we eat being more important than the amount of food that we eat, and that it wasn't about being low fat. It was really about a low sugar diet is probably the best way to achieve good health, and it made a lot of sense. And I said, okay, let me try it. Nothing else has worked for me, so let me try this. And I did, and I had good success with it. And that led me to ask, why hadn't I heard about this?
Mm.
Why did I learn about this from a journalist? And again, that's not said in any negative way, and Gary, I highly respect. But why did I hear about this from a journalist instead of from my colleagues? Or why didn't I learn about this in medical school? And that, led me down to a journey to, ask lots of different questions. And as you said, sort of get deeper and deeper into the vortex, and ultimately to really question, what really is the root cause of heart disease? The disease that I had dedicated my career to treating. And I came to realize that I didn't even properly understand what caused it in the first place.
Oh my goodness. Okay, so what causes it in the first place?
Yeah, well, it's the food we eat first and foremost, and it is, what we call metabolic health. And if you want to get very medical, you call that insulin resistance. But ultimately, it is eating the wrong foods. And and some of your habits, things like smoking, come into play as well. But what's really ironic is, and maybe ironic isn't quite the right term for it, but one of the sort of shocking things that I came to learn is that, the things that we do in medicine to try and prevent heart disease, telling people to eat a low-fat diet, is actually making the problem worse. Because, again, it's looking at the problem from the wrong standpoint. It's looking at a downstream player in the process, cholesterol, and it's saying, okay, well, if we attack the cholesterol, we're going to fix the problem. But cholesterol is not the root cause. Like I said, it's a one step down the stream in the process that contributes to heart disease. But because we're not addressing the root cause, we end up actually making the problem worse.
Absolutely. And so, I want to make sure that everyone who's listening knows this is one of the things when I first started talking about nutrition, I felt that some people in the audience were triggered, like, oh, because I'm talking about diet or weight. And this is really not that conversation. The conversation is not about weight loss. That will happen, but the conversation is about the quality of the nutrition that you're eating. Because I have plenty of what would be considered thin patients who are insulin resistant and have really high cardiac risk. So this is not a conversation of what you weigh on the scale or how you look in a bikini. This is really a conversation of the quality of nutrition, the inflammation that it creates, and what it does metabolically to your body. You could be relatively thin, but you're eating potato chips all day long. This is not going to work out for you. Or maybe not potato chips, what's low fat? A low fat, cookie, because it's low fat and you're eating it all day long because your thought of low fat means good, and you're actually creating insulin resistance. So I'm glad you say that. So if you're saying cholesterol is not the root cause, would you say root cause then is inflammation or sugar?
Yeah, well, so, I would say it's inflammation, it's blood vessel damage. And then we have to say, okay, what's causing the blood vessel damage? And sugar is one of the major things there. And again, we know this, we have the science to show this. We just don't pay attention to it because, it doesn't fit into that paradigm that medicine likes, that we give a medication or we do a procedure to address the problem, and we don't have the only way to address metabolic health and insulin resistance is through diet and lifestyle changes, and those are hard for the traditional medical system to really wrap its head around and put into practice. Our medical model does not support doing that. And I know, that involves time. It involves the conversations, educating the patients, and quite frankly, our medical system has become overwhelmed taking care of sick people, and it just doesn't really leave time to ask those questions of what should we be doing to keep people from getting sick in the first place.
Absolutely. Healthcare is a misnomer. It's absolutely sick care.
Yep.
What we do all day is take care of the sick. But to really move the needle on health would be to have prevention, to have time, and the system would have to pay to give you the time it would take to really get down to figure out lifestyle modifications. Like, hey, Mr. Smith, what's in your way? Is it because, you have two jobs? Is it hard for you? Well, let me talk to you about what you can get, like what choices you can make at a fast food restaurant. Like, what's the reality of your world, right? That takes time. To just, you handing out a piece of paper is not what it's about. What are your limitations in your life? Is it financial? Is it time? Is it because you have 6 kids at home? Let's work through that. Let's come up with better options. All of that takes time. And it's not possible in a 5-minute window. And you need to see people in a 5-minute window because that's how the fee structure is made. So it's really designed to keep people sick. That is a whole episode in itself. But I want to say that because it's impossible to ask this of your primary care provider or anyone who's insurance based. It is impossible. Don't get mad at them. possible. One, they didn't learn it in school, and two, the system does not allow them to delve into it. But I want to ask you, why did cholesterol get center stage?
Well, you know, it's interesting when you look at the journey as to how we got here, and believing that cholesterol is the sort of end all and be all when it comes to heart health. And, you know, it really starts with some science. You know, we really have to go back to the 1950s. And at that time, the incidence of heart disease was rising at a very alarming rate. And our president, you know, the president of the United States, had a heart attack while he was in office. And this, you know, appropriately set off the alarm bells. And there were really two competing schools of thought at that time as to what was causing heart disease. And it basically came down to, you know, sugar, which there was a lot of science to support as being the primary driver of heart disease. And then there was, you know, dietary fat. And specifically, there was a scientist at the time by the name of Ansel Keys, who was very, you know, promoting the theory that it was the fat in the diet that was causing heart disease. We know in retrospect that a lot of his science was somewhere between poorly done and intentionally
Wow.
misleading. And you know, we look at something like what became, you know, the foundation of the diet heart hypothesis, which said that you know, the amount of fat that we eat, specifically the amount of saturated fat that we eat in our diet, increases our blood cholesterol level, and that increased blood cholesterol level is then, you know, what leads to heart disease. The study that Ansel Keys, you know, put forward to support that theory, it was called the 6-country study. There was a follow-up called the 7-country study, but basically what he purported to show in that study was that the amount of saturated fat that's eaten at the population level, you know, in countries, correlated to the amount of heart disease that occurs in those countries. And he has this beautiful graph with the 6 countries, and it's a nice straight line showing this relationship. The problem is that Ansel Keys had access to 22 countries' data. And when you plot out all 22 countries, there's really no relationship there. But he handpicked the 6 countries that make that nice graph. And he ignored other countries like France, that at the time had the highest, you know, the highest consumption of saturated fat and the lowest incidence of heart disease. So,
Convenient.
you know, yeah, very convenient. And then Ansel Keys was, you know, quite frankly, very good at public relations, at promoting his theories. And he was able to get, you know, on the medical team, you know, that was taking care of the president at the time. And then he became ingrained with the American Heart Association and was able to push his theory forward. But the problem is, here we are 70 years later, and neither part of that hypothesis has ever been shown to be definitively true. We have lots of conflicting science around the relationship between how much saturated fat you consume and your blood cholesterol levels. And we have lots of conflicting science between your blood cholesterol levels and whether or not you get heart disease. Yet it just has become the popular theory. What really then pushed it forward was in the late 1980s when we developed medications to lower blood cholesterol levels. And once the pharmaceutical industry basically got involved in this, they, you know, put their PR machine on it, and cholesterol became all that doctors talked about. They got involved with the medical education system. They get involved with setting the guidelines that doctors are supposed to be following. And here we are, you know, 30 years later from there, approaching 40 years later now, statin medications, the medications that lower cholesterol, are the most widely prescribed class of medications. And yet heart disease remains the #1 killer in the United States. So those are the facts that don't quite line up for me. And these are the things that I started to have more questions about. And like I said, when you really do dig into the science, you can see that cholesterol clearly isn't the whole story. Is it part of the story? Yes, it is. But it's not the whole story. It's not the root cause. And therefore, just focusing on cholesterol is a very ineffective way of trying to deal with the heart disease problem.
This is amazing. So there's like a few things happening. So what we're saying is that fat is not necessarily number one is that fat is not necessarily the cause of increase in cholesterol, and two, that cholesterol is not necessarily the cause of heart disease, right? And we're in a country
Right.
that has the most amount of low fat foods, yet here are cholesterol, and
Yep.
as you said, the most amount of statins. And so then a lot of people say, well, then why are statins prescribed? And why are statins working? And I think, correct me if I'm wrong, the answer is not necessarily because they're reducing cholesterol, but because they're reducing inflammation. Right.
Yeah, exactly. So, what you see when you really look at the data around statins is that there is a small effect on the incidence of heart disease. But interestingly, that effect is not related to how much you lower someone's cholesterol level with statins. And what I think is a theory that makes a lot of sense, really not investigated because, quite frankly, I don't think the drug companies really want people to know this. But when you really look at it, it is probably the anti-inflammatory effect that statins have that lead to most of their benefit.
So in essence, if we have high cholesterol, and we're not telling anyone to come off of meds or giving medical advice, but if there was a way for us to reduce inflammation and we could do that, that would be as effective as taking statins, because ultimately what we're trying to do is reduce inflammation. Is that accurate?
Yeah, I would definitely say so. And, my message to anyone who is, dealing with heart disease or concerned about heart disease is, figure out where you stand in terms of inflammation, figure out where you stand in terms of insulin sensitivity or insulin resistance, and, address those issues first and foremost, because when you eliminate inflammation and you eliminate insulin resistance, you eliminate the vast majority of heart disease. We have data going back again to the 1970s and the 1980s, showing that 95% of patients who come into the hospital with a heart attack are insulin resistant if you measure it the right way. When you look at the data on cholesterol, it is nowhere near as clean. The studies that looked at patients who came into the hospital with heart attacks before we had statin drugs, before we were lowering people's cholesterol with medications, it showed that basically 50% of them had what today is considered low cholesterol, a good cholesterol level, and 50% of them didn't. So, again, it really shows you that cholesterol is not the key to heart disease.
So how would you say is the best way to measure inflammation? Are we talking about just CRP, or do you have another way?
Well, yeah. So I really step back, and we want to look at the metabolic health picture. That's really what we want to look at. And there are 5 basic measures for that I encourage people to pay attention to. 2 of them aren't even blood tests. 2 of them are things you can measure at home: your waist circumference and your blood pressure. Then we look at a couple of blood tests. We want to look at your fasting blood glucose level, and we want to look at your HDL cholesterol, that good cholesterol number, and we want to look at your triglycerides. We're not looking at your LDL cholesterol, the number that most doctors focus so much on. The interesting thing about the HDL and the triglycerides is that it is an indirect way to get a sense of whether or not you are insulin resistant. Ideally, you want to do the direct measures of your insulin resistance. You want to get your fasting insulin level. You want to maybe do what's called a Kraft test to help you figure out if you're insulin resistant or not. But that's what we're really trying to figure out. Inflammation is another, something else to be paying attention to. I think that CRP, like you mentioned, is probably the best test to do that. But if you're just looking at your metabolic health with those 5 metrics, you're going to get a pretty good sense of whether you need to be concerned or not.
That is really great. When you say waist circumference, what is the parameters?
Yeah, so if you are a man, you want that to be less than 40 inches. If you're a woman, you want it to be less than 35 inches is the cutoff that we're looking at there.
Okay. And that's interesting that you say waist circumference, because it gets rid of the whole BMI concept, which is so problematic.
Exactly. The reason that waist circumference in and of itself is such a powerful measure is because it really reflects whether or not you have visceral fat, the fat on the inside. And again, the visceral fat is kind of where a lot of the inflammation starts from. It's our body's response to being in a poor metabolic state. Our body starts to build up this visceral fat around our organs. And that, again, ends up secreting a lot of the hormones and a lot of the things that come into play in the whole process. But again, if you're looking for sort of root cause measurements, we know that reducing visceral fat improves your overall health and lowers your risk of disease. So visceral fat is a great thing to pay attention to. It's just hard to measure. So the indirect measure, the best thing we have is your waist circumference.
Absolutely. So I like to tell my patients, I'm like, visceral fat. So visceral is a fancy word for organs. So if you don't want your organs surrounded by fat. So when you eat more than you need to, right. So we're always kind of know, okay, well, I'm not diabetic. I checked, I went for my annual, I'm not diabetic, I must be fine. But there are years and years before you become diabetic where you are in this insulin resistance stage, and you might not know it because every time you go get your A1C checked, it's fine. You might not even be pre-diabetic if that's what you're looking for. In fact, I used to believe that A1C pre-diabetes was like an early marker of diabetes. I've come to appreciate that's pretty late. So as you consume more and more food, more than you need, I'm not saying you're out there engorging yourself, but more than you need, your body doesn't know what to do with it. So one of the things it does is it starts to create fat, and it kind of wraps your organs in fat. And by default, since now your organs have fat, your waist can get bigger. And so checking your waist, and so the best way to see it would be ultrasound, but who's going to get ultrasounded all the time? So what you're saying is that, okay, the waist circumference gives an indirect measure of like, well, you probably don't have too much visceral fat, too much fat surrounding your organs if your waist is under 40 for men and under 35 for women. I love that. And for those of you who don't know, look up why BMI is racist and it's a problem. We're forced to use it in medical offices because that's what insurance wants us to see. But using the waist is so direct and gets rid of like all that nonsense. So that is great. Blood pressure being high is kind of obvious, and you can do this at home. And it's really important that everyone does that at home because it's a silent killer. You don't even know you have high blood pressure. So do those 2 things at home. If those 2 things are off, it's probably time to come in to see your primary care. But then even when you see your primary care, you're kind of screwed because they're just going to do an A1C. So you have to be savvy enough to ask, hey, I don't want just the A1C, right? Because the A1C, for those of you who don't know, is kind of like a 3-month average of the sugar that you have in your blood, but you may not have excess sugar yet in your blood. You may not be at that point yet. So the average looks normal. So you want to go before that. The fasting blood glucose is when you're fasting, that should be low to normal. And if it's high, that's problematic. And that might happen for a long time before your A1C shifts. Tell me why you don't focus on the LDL and why everyone else does.
Well, yeah, like I said, when you look at the statistics around LDL, you just see that it is a lousy marker. Half of the patients who come in with heart attacks have a
Oh, that's
normal, what would be considered a low to normal LDL level. So ultimately, I just, and the other thing that I see, as a heart surgeon is that, a lot of the patients who end up on my operating table have low LDL levels. Some of them are on medications to lower their LDL. Some of them are not. They just have naturally low LDL levels. So I just don't think it's a good enough marker for us to be focused on. And I think the real problem is that it distracts from those other markers.
mm,
If we were putting our efforts into measuring insulin levels and measuring these metabolic health measures, we would be making much better progress against the problem. And so that ultimately becomes my problem with LDL, is that it distracts us from what we should be focused on. The other issue that I have with LDL is, outside of the medications, the other advice we give in this effort to lower your LDL cholesterol level is to eat a low fat diet and
right.
to eat, overly processed foods. We have to realize that low fat foods are processed foods. They have been altered to take out the fat and to put in something else. And usually that something else is sugar. And so like I said, it ends up making the problem worse. We also, promote these highly processed vegetable and seed oils because they
Mm,
lower LDL cholesterol levels. And yes, they lower LDL cholesterol, but they don't prevent heart disease. And again, there's science to show that the more of these you consume, the worse your overall health becomes, the shorter you actually live when you're consuming these vegetable and seed oils. But we get distracted because we see that it lowers LDL cholesterol, and we're so convinced that that's a good thing to do.
yeah, that and Quaker oats for some reason, super with cholesterol. That's like a head
Yeah,
scratcher for me. Not really
yeah.
sure. Tell me about why the focus on triglycerides. Is it because it's an indirect measure of how much of sugar?
Yeah, exactly. So triglycerides really reflect, so what the purpose that triglycerides ultimately serve in the body is that they take your excess energy intake, and they are transporting it basically to your fat cells to be stored. So the more, the higher your triglycerides are, it basically reflects that you're taking in excess energy, and that's usually in the form of sugar. It really, now that I work with people and we make these dietary modifications and we lower their amount of sugar, we pretty reliably see their triglyceride levels coming down. So again, I think it's sort of an indirect measure, like I said, of the problem that we're focused on. But it's a good enough measure that if someone comes to us and their triglyceride levels are high, we know that there's a problem.
It's so
And
funny
it's
because
interesting again,
no, please go
yeah,
ahead.
when you look at the data around heart disease, prediction based on blood work, you see pretty consistently in the studies that triglycerides being elevated are a much more powerful predictor of heart disease than your LDL cholesterol being elevated. But again, we don't have drugs that reliably lower triglyceride levels, and therefore we don't focus on it in the medical system.
And it's funny because when my patients come in and their triglycerides are high, they're like, "Oh, I should eat less like fried foods and oil foods." I'm like, "No, you need to reduce your carbs." And they're like, "What does carbs have to do with it?" I'm like, "This is why your triglycerides are up because you eat a lot of sugar." And it's hard to wrap
Yep.
around, right? Because we've been taught for so long that the fat. It's just fat, and it really isn't. Um, so where do you use the calcium score test at all in your office? And can you tell a little
Yeah,
everyone else what that is and how you use it?
definitely. So the coronary artery calcium scan, CAC scan, you'll hear it referred to, I believe is one of the best tests to determine if you have early evidence of heart disease. So again, when we're looking at heart disease and um, trying to prevent it from becoming a significant problem, way before you have the heart attack, you can find the early signs on a coronary artery calcium scan if you have damage to your heart, damage to the blood vessels in your heart is essentially what we're looking at. So to step back, what is the scan? It is a type of CAT scan, CT scan that's done. It's very easy to do. They don't even have to put an IV in you. You literally just lay down on the table. It takes about 5 minutes to do the scan, and it's going to show you at the early stages heart disease developing. And if we can determine who has the early stages of heart disease, we can then, really focus on stopping that from getting worse and making the changes that are going to stop it from getting worse. So I'm a big fan of the coronary artery calcium scan. I believe they should be, utilized way more than they are. Like I said, they're an easy test to do. They're relatively inexpensive. The unfortunate thing is most of the time insurance doesn't cover it. But you can find them as cheaply as $50 in
Mm-hmm.
many locations. And at the high end, you're maybe going to pay $200 for it. And I think it's a very worthwhile investment because, again, it will give you an idea of whether or not you have heart disease developing at the early stages.
So what you're saying, and I want to make sure our listeners understand that you might be walking around with a cholesterol number that's high, but if your calcium score is 0 and your HDL is good, your waist is good, your blood pressure is good, triglycerides good, your fasting blood glucose is good, that high cholesterol number is pretty much meaningless.
Yeah. And this is one of the reasons that coronary artery calcium scans probably don't get used as much as they should, because you're right. The data shows exactly that. If you have a coronary artery calcium scan of 0 and you have no other risk factors for heart disease, no matter what your LDL cholesterol level is, there's not going to be a benefit to using statins in that situation.
And since we don't want to disprove the use of statins, we're not going to do the calcium score because we want everyone on a statin. That is, I'm being ironic, everyone. I have 2 patient populations I want to ask you about. One is the postmenopausal female, right? So we know that the postmenopausal female, as a result of sex hormones dropping, will have an elevated cholesterol unrelated to dietary modifications, right? So I'm talking about, you're postmenopausal, you're eating the same way, you're eating a healthy diet, and then all of a sudden your cholesterol jumps up. All of a sudden, these women are put on statins, and there's like this big fear. Now, it is my understanding that the reason, now we do know that postmenopausal women have suddenly a higher risk of cardiac risk, but it's my understanding it's not because of the cholesterol, it's because they're losing estrogen, and estrogen is cardioprotective. Can you tell me a little bit more about that? Should we be chasing this postmenopausal cholesterol rise if we know for sure it's secondary to the hormones as opposed to dietary?
Yeah. So, again, when you look at, why do women, when they go through menopause, kind of all of a sudden become at higher risk of heart disease. And it really, again, seems to track back to that insulin resistance. One of the things that occurs with going through menopause, because of those hormonal shifts, is that women become more insulin resistant. And that is really, again, what is driving their risk of heart disease. The whether their cholesterol goes up or not, again, I would say is probably not relevant, not very relevant to the discussion. And what I focus on with, women, again, postmenopause or premenopause, is you want to remain insulin sensitive. You want to make sure that you're insulin sensitive. But, typically what we see is that women are able to maintain that insulin sensitivity until they get to menopause, and that's when it oftentimes becomes apparent, and that's what we should be focusing on with them. And we just do a lousy job of looking at that again.
Yeah, absolutely. Well, I mean, I do have a patient population that insulin resistance is not where it's at, and it's definitely, and it just jumps up postmenopausally. And I just really want to kind of drive home the fact that those numbers suddenly being elevated, if everything else is in check, is irrelevant. Again, if everything else is in check, you're not insulin resistant, your calcium score is on point, and your HDL, like all that is good. What
Right.
about those who say, hey, it's familial, and they really is familial? I've had this, my whole family has this. What's your answer to them? Why is it that some
Yeah. So
cardiologists feel they're a higher risk?
Yeah, so true familial hypercholesterolemia, which means that you have certain genetic, changes that truly cause you to have an increased level of cholesterol. And these are people who usually have very high levels of cholesterol. Typically, over 300 is when we start, considering that as a diagnosis. And it's interesting when you look at familial hypercholesterolemia, that yes, it does increase your risk for heart disease, but really not quite as much as you would predict it would. And it may, again, not have really a whole lot to do with the cholesterol itself. One of the other features of familial hypercholesterolemia is that many of these patients have alterations in their blood clotting, that makes them more prone to blood clot formation, which does play a part as well in the development of heart disease and having heart attacks and strokes. So familial hypercholesterolemia, if you truly have it, is certainly a situation where you want to be working with a physician who understands that and can help you understand, is it the cholesterol? Is it something else? How much do I need to be paying attention to it? But again, understand that that is a relatively uncommon condition. The reason that heart disease really appears to run in families, and the reason that we sort of have this notion that it's genetic, is because families pass down habits,
Yes.
just like they pass down genetics. And I really do believe it's the habits that are more important.
I agree.
And when I have many patients now, and they have strong family histories of heart disease, and they make these changes. They pay attention to their diet and lifestyle. They get their insulin sensitivity back. They get all their other markers in line, and it doesn't seem that they are any longer at high risk of heart disease. The other interesting thing about the genetic, sort of argument around heart disease is that heart disease has really only been a problem, for people here in the United States. Like I said, 1950s is when it started elevating. But it really, heart disease was almost undescribed prior to 1900. We have reports from many prominent physicians, the busiest physicians of the time, from, the early 1900s, the late 1800s, and they basically never saw heart disease. So genetics, on a population level, don't change that quickly. Human genetics have not changed in the past 150 years. Something else must be driving the heart disease. And what has changed in the past 150 years, again, are our habits, are the foods that we are eating. So that is really, the explanation for why heart disease has become such a prominent problem.
Oh my God, that was great. It's so true. It's the habits that are passed on. Then yeah, 100%. I have one last question for you. And so you and I agree on everything, except I feel like where we differ is that you call yourself a carnivore, which I do not call myself a carnivore. I would say that I promote, and then I want to give you the opportunity to explain your side. I promote what I call plant-based, meaning I want your plate to be as colorful as possible with plants, with, unless it's ethically against, your beliefs, with a animal protein on that plate, but I want there to also be a lot of plants. When I hear the word carnivore, I feel like there's less of a focus on the plants as well and more a focus on the animal protein. So can you tell me what you mean by promoting a carnivore diet?
Yeah, sure thing. So, my high level principle around what we should be eating is we should be eating whole, real food first and foremost.
Amen.
And I am open to, the variation that will come within that. It can be, you can do a whole, real food diet as a vegan and as a carnivore. Um, and honestly, I don't know for sure that there's unique advantages to one over the other. What I do see though is, first of all, I think a lot of vegan diets end up being highly processed. All of this fake
Potato
meat
chip
stuff.
vegans, I call
Uh,
them.
yeah, and Oreos are technically vegan,
Yes, yes, yes.
and on the meat side of things, we see less of that. Yes, there are processed meats, but I think it becomes less of a problem. I also look at, we as human beings evolved eating meat. There is absolutely zero evidence that red meat is harmful to our health. In well done studies, we have some low quality evidence again, but we don't have any good evidence that red meat by itself is harmful to health. So I want people to understand it's okay to be eating red meat. It's okay to be eating vegetables, but there's also nothing unique that you can get from vegetables that you can't get from eating meat. And so, you know, um, the opposite can't be said.
What
We
about,
know that if you,
so I agree with you. I think the vegan diet is a little bit harder to achieve
yeah,
getting all the nutrients because you could very easily be carb heavy. I agree with you. So when I say plant-based, I definitely don't mean vegan. I do have
right,
some patients that are vegan. It's challenging because getting all that right.
yep.
But what about the phytonutrients? How are you getting that in your meat unless you're saying secondary to the animal eating it, you're getting it?
Well, that's exactly what I'm saying. The
Okay.
animal eats the plants. The animal, especially ruminant animals, are uniquely designed to extract nutrients from plants. We as humans, being monogastric, having one stomach, we can't as effectively extract those nutrients. So I would rather let that cow do the work for me, and then I eat the cow and I get the benefits of eating the cow. So that is what I have found works best for me. I do not tell all my patients you need to be carnivore. I think if you're doing a mixed whole food diet, you're eating plants, you're eating animals, I think you're going to be fine. It just a lot of it comes down to, one of my other principles. If you're trying to lose weight, if you're battling obesity, you want to make yourself hungry less often. And the best way to be hungry less often is to be eating a lot of animal protein. And
Sure,
so
because the fat
that's
keeps you
why,
full.
yep, the fat and the protein keeps you full. And I think it's hard to get that same level of satiation from a primarily plant-based diet. When I look at my patients or my friends who are doing, more of a whole food plant-based diet, one of the things you notice is they're eating almost all the time. Uh, you know, as opposed to people on carnivore diets, I'm hungry once, maybe twice a day. I typically eat once or twice a day, not because I'm intentionally, fasting or, restricting myself from eating. It's just I'm truly only hungry. If I sit down and I have a big meal of animal protein, that keeps me from being hungry. So that's why carnivore has worked best for me. Like I said, I don't tell everyone they need to be carnivore. I do have concerns about vegan diets. And I think if you're going to do a vegan diet, like I said, it needs to be a whole food vegan diet, you can't be eating processed food, and you're going to have to supplement because there are
Agreed.
certain essential nutrients that you can't get from plants alone. But if you want to incorporate some plants, along with your whole food diet, honestly, I don't have much trouble with that. Fruit can be a different issue. If you're
Agreed.
metabolically unhealthy, we need to acknowledge that fruit is sugar, and so you have to be careful about that. But the vegetables, yeah, I don't have much problem with
Yeah.
it. I just want people to understand they're also not essential. You can be very healthy without eating them. So it comes down to a lot of what your preference is.
Yeah. I mean, I agree with a lot we're saying. I do agree that vegan diet is challenging because it's very easy to go processed and they do need to supplement. Fruit is a problem because sometimes I'll have people come in and say, "Oh, I had a fruit smoothie." I'm like, "You just had a glass full of sugar. It's just God's sugar. It's still sugar." So that is a problem when you're trying to, um, especially when you're trying to lose weight or reduce insulin resistance. It's still sugar. I am still a big fan. This is where we don't agree. I am still a big fan of making sure your food has a lot of colors on it, along with an animal protein. But I think ultimately you're achieving by eating mostly animal protein. And I also am a big fan of intermittent fasting. You are achieving that metabolic flexibility where you are burning fat for fuel as opposed to carbs. We're just getting
Yep.
there a little differently. But I think that is what keeps you efficient. That is what keeps you less hungry. Um, and ultimately, I think you and I are getting to the same place, small, slightly different pathway, but still in the same, with the same idea in mind. Um,
Yeah, I would definitely agree with that. I think when you really look at it, the difference between, you and I, is pretty small. And we all agree on the same thing,
yes.
don't eat the processed food.
Don't eat the processed food.
And I think
Slow
that's
down the
really
carbs.
rule number one. Yeah, yeah.
Yeah.
If someone comes to me and they say I'm not eating processed food, I'm going to be pretty happy with what they're doing. And, maybe we're going to be doing some minor tweaking from there. But if you get to that point that you're not eating processed food, it's probably a very small difference as to whether you're doing it as a meat heavy or a plant heavy diet.
I love that. And if someone is on the verge of if someone's being told they need a statin, how much time, if they say, "Listen, I don't want to do this. This is my wake up call. I really want to turn this around." How much time would you give them? Would you say 3 months? Hey, let's see if we could turn this around in 3 months before you said, you really, is there ever a time when you're like, dude, you just got to go on the statin?
Honestly, the only time that I think it makes sense to go on a statin is if you're not going to address the underlying metabolic health problem.
Mm-hmm.
If you want to just keep eating your processed food and you're not focusing on your metabolic health, then yes, there may be a small benefit to being on the statin versus not being on the statin. But I want people to understand that being on the statin alone is really not going to
Not gonna
address
move
your
the needle.
problem. It's not going to correct your problem. You can see changes in your metabolic health very, very quickly. Within a couple of weeks, I oftentimes see people's blood measures improving.
Mm-hmm.
If you're looking at visceral fat levels, or fatty liver disease is sometimes the best way that we look at this, you can see that start to reverse pretty quickly within a few weeks when you eliminate processed food and you minimize your carbohydrate intake. These measures get better very quickly. One of the ways that it shows up most, with the patients I work with, they come to me and they're on high blood pressure medication and they're on diabetes medications to control their blood sugar, and they stop eating the processed food and they stop eating the processed carbohydrates. And, within a couple of weeks, oftentimes, their blood sugar is getting too low and their blood pressure is getting too low.
Yes.
And we need to cut back the medications. So, that shows you how quickly the body can start to respond. Are you undoing all the damage in that time? No, of course not. If you've
Sure.
been doing, if you have, 40, 50 years of damage built up, it's going to take longer to really start to undo that. But you can at least start to, you see that you're moving in the right direction.
This is amazing. Dr. Vadia, tell people how they can reach you if they want to set up a time to meet you.
Yeah, sure thing. So the best place to go is to my website, ifixhearts.com. All my resources are kind of linked there. I have the book, like you mentioned, Stay Off My Operating Table. I have courses that people can take, just kind of self-study courses about metabolic health. We have group coaching programs, and then I have my private medical practice, Ovadia Heart Health, where I work with people one-on-one on these issues. If you want to come find me on social media, I'm most active over on Twitter. Again, iFixHearts. You can also find me on Instagram, YouTube. I haven't done the TikTok thing yet, but on all the other social media places, you'll usually find me.
That's amazing. This was as amazing as it was when I was on your podcast. This is so wonderful. I really appreciate your time. So now you guys know where to find Dr. Ovadia. He's amazing. Thank you so much for being here with us.
Thank you.